brain thinking a little bit now. I'm going to give you a think and share type of exercise. This is the case. There's an intubated patient in acute respiratory distress. PF ratio is 108, peak 15, FiO2 of 1. O2 stat remains low at 86 regardless of optimizing ventilator recruitment strategies. The team is planning to phone the patient within the next hour. So I want you to think individually with your group what options of pharmacotherapy you would consider, your team would usually consider, starting on this patient and why. So take 3 seconds, a couple seconds to think and share. I do have a QR code here, but I took out some polling software. Hopefully it pops up.
It's anonymous.
Okay, so I think it's coming out on the bottom. I see here somebody says Nindex, Cherie.
Yeah, that's me. I couldn't spell it.
Propofol, some fentanyl. I like it. More Nindex. So for marketing reasons, we'll put Cherie on. Okay, just to test some of that out. Hopefully this works for you people in the virtual world as well. I'm sure. Or you can kind of see it on the screen. Hopefully this will test some of the other stuff. Got a lot more fentanyl, Cherie, and propofol, more propofol.
Do you want to go this way?
Okay. So those are some of the stuff, and I'm very surprised. Nobody brought up the biggest drug class used, I guess. Oh, Flowland. Oh, geez. Okay, we'll talk about Flowland and epoprostenol, those prostaglandins a little bit later, a little bit about paralytics. Not so much sedation. I thought the most important thing everybody was going to get bored about talking about were the steroids. So every time you think about, ARDS, or in my mind, as a pharmacist, I'm like, oh, geez, here's the steroids. And EHAB asked me to talk about this, and I'm like, you just want me to talk about steroids for 30 minutes. So I just put a few things in here about steroids. When you think about steroids and ARDS, it's usually these 3 players, dexamethasone, methylprednisolone, and some of the studies look at hydrocortisone, and those are the sepsis studies. This is a timeline of the history of steroids. It's truncated, and I just kind of gave you the biggest studies out there. It just helped mold what we do today. So back in 1987, we had the first study looking at high-dose methylprednisolone. This is a 30 milligram per kilogram dose, which is a huge dose when you think about steroids. This one actually showed improved mortality. Then we have a 1998 Maduri and colleagues put out their low-dose prolonged infusion methylprednisolone study, where they found that it improved lung function and mortality. Later on, we have the Lazarus study that Steinberg and his colleagues put out. This study showed that steroids after 14 days showed no benefit, but prior to 14 days of initiated, it did show some benefit in mortality and improved ventilator days. Later on, we have the main study. So this is the sepsis study where they looked at hydrocortisone in sepsis or septic shock with ARDS, and they showed a benefit. In 2007, we have the Maduri study, which looked at methylprednisolone infusion and it lowered ICU mortality, improved lung injury scores, and decreased ICU days. Then skip forward to 2016, and we had the Tongyo study put out in critical care. This one showed not so much a great benefit for hydrocortisone in ARDS and sepsis. And then after that, we're looking at the more studies looking at the benefit of corticosteroids. So we have the Codex study by Tomazzini and colleagues.
That one looked at dexamethasone in COVID-19 patients with ARDS, and this showed improved ventilator-free days. Later on, the DEXA-ARDS studies, or the study put out by Villar and colleagues, this one looked at dexamethasone use in ARDS patients regardless of COVID-19 or not. And that also showed improved mortality, decreased ventilator days as well.
They came in, two people just came in.
Pooled meta-analysis showing that glucocorticoids were very beneficial in ARDS patients, and it reduced mortality overall. So we learned a lot from these studies. This is what we know. There is some mortality benefit. There's more ventilator-free days with the use of glucocorticoids. It improves oxygenation, and you should be using low-dose corticosteroids, not that huge 30 milligram per kilogram dose. We want to start early. That Lazarus study showed us that you have to start these steroids early before 14 days to see any mortality benefit. The last part here is there is questionable effect in viral pneumonia. COVID-19. So I would probably avoid using it in those, influenza patients, RSV patients, because there's no proven benefit for glucocorticoids in those patient populations. Here are our main players. I kind of put them out there as a pharmacist that give doses. If you wanted to know some doses, we have methylprednisolone. The usual dose is anywhere from 1 to 2 milligrams per kilogram a day. You can use it up to 21 to 28 days. We don't typically go longer. The studies don't support that. And usually by then, the patients will kind of declare themselves, and you'll hopefully start to wean them, or they'll declare themselves in the other direction. Okay, then we have dexamethasone. So the DEXA-ARDS studies actually established this dexamethasone dose of 20 milligrams IV once daily for 5 days, and then you taper it after that. And then you have the COVID-ARDS dose, everybody knows now, Decadron, dexamethasone 6 to 10 milligrams daily for 10 days. You can do either oral or IV. And lastly, we have hydrocortisone. This is the sepsis stress dose for steroids, so it's the 50 milligrams Q6 or the 100 milligrams Q8. So how do these steroids work? Basically, in a nutshell, this looks super confusing. I know as a pharmacist, this makes a lot of sense to me. For you, simplifying this, corticosteroids enter the cell, and basically they decrease inflammatory mediators, which means decreasing inflammation. Simple. We got it. They decrease inflammatory mediators by getting rid of the inflammation or preventing inflammation. They have an anti-inflammatory, anti-fibrotic effect. And they're also a little bit vasoconstrictive, so they can decrease with the pulmonary edema as well. A nice chart for those of you who want to know the differences between these steroids. We have hydrocortisone, prednisone, methylprednisolone, and dexamethasone. It just compares the activity, the duration of action, equivalent dosing. So equivalent dosing meaning based on hydrocortisone as the parent drug. So the activity is based off of how active hydrocortisone is based with respect to all the rest of the drugs. Just of note, there are oral and IV formulations for all of them. The only one that does not have an IV formulation is prednisone. Bioavailability is very, very good for oral formulation.
Can you get me with her too?
Okay, so hi, it's me, I'm the pharmacist, it's me. For all you Swifties out there, or if you no, I don't know what this guy is from. Breaking Bad.
Yeah.
Okay. Just as a pharmacist perspective, and I annoy EHAB with this all the time, is what do you want to do with those steroids? So in my head, when I see all of the physicians or my providers put in for steroids, I'm like, okay, how long is this going to go? Are we going to taper this? So there's a theory that you should gradually taper after 48 hours. There's another theory that says, if it's less than 5 to 10 days, you just stop it. Some of the theories behind the gradual taper is that it helps you preserve the improvements or the beneficial effects of the drug, so you don't just stop it and see any kind of rebound of the ARDS. So gradual taper, okay, if used for more than 48 hours, you can taper day by day, half every single day to off or to an oral steroid if needed. Post-paralytic quadriparesis or myopathy, this is a thing, especially if used in combination with some of the paralytics, like not cisatracurium, but rocuronium, vecuronium. Just due to the similarity between the chemical structure, they both are very similar to steroids. Psychological derangements. Roid rage is a thing. And some of the physicians I've talked to before are like, oh no, that's okay, it's okay. I'm like, no, have you ever been on a prednisone taper pop? It makes you crazy. Like, it makes me crazy and hyper and insane. So I don't know how bad the effects are on these higher dose steroids on some of these patients. Just be cognizant of that if they're having sleeping derangements, and maybe it's because of the steroids, and maybe that's a sign maybe you could taper it off earlier. I'll ask. But you can say no to me at any time if I'm asking. I understand, but that's something your pharmacist may ask you. Hyperglycemia, yes, these are steroids. They do tend to cause a lot of hyperglycemia. And you also have to think about adding stress also prophylaxis to these patients because, again, one, they're under extreme stress if they're in this state already. And then two, those steroids tend to increase the susceptibility to stress ulcers. Okay, now moving on to paralytics. I can't talk about paralytics without talking about lung protective ventilation. And by all means, I am not an expert on lung preventive ventilation, but I do know the studies and they're related to the use of paralytic. The first is your Accurus study, put out by Papazian and colleagues. That was back in 2010. This is a study where they looked at deep sedation and low tidal volumes using conventional PEEP. So this is where we sedate the patient, sedate super deep, RAS -4, -5, and then we use some lung protective techniques. And then later on, just recently in 2019, we had the ROSE study. This study used lighter sedation, RAS scores of 0 to -3 with low tidal volumes and high PEEP. Just of note, these two studies did not include patient populations where they prone them. So they did not look at the effects of proning in these patients, just the protective lung ventilation and the use of paralytics or sedation. So lung protective ventilation and paralytics, we have this group. This is the Intensive Care Medicine Rapid Practice Guideline group. They put out this very nice algorithm talking about, okay, if you have a mechanically ventilated patient with ARDS, you optimize the vent, then you have to determine when to start paralytic or not. So based on this algorithm, you see, you optimize. If you can't get optimization, you can try a neuromuscular blocking agent, or you can try to deeply sedate or better sedate your patients. Okay. Usually if you're able to ventilate appropriately, at that point you just stop. If you need more assistance or help with ventilating, you can choose to give intermittent boluses or to start a continuous infusion of the neuromuscular blocking agent. If you do use neuromuscular blocking agents, it's recommended to try using bolus dosing first and optimize your sedation. If you need more than that to prevent ventilator-associated lung injury, then you can start your continuous infusion, but we recommend not to go longer than 48 hours, if possible. So the key takeaways here is kind of all about the ventilator. High PEEP. You want to use lighter sedation, like the ROSE study said, there's better outcomes with lighter sedation. If you're going to use paralytics, use them sparingly with IV bolus dosing versus the continuous infusions. The whole point of this is to recognize the need early and start them early, and don't go longer than you need to. If you're going to use a paralytic, we recommend to use cisatracurium. There's really no data looking at all the other paralytics, like rocuronium, vecuronium. All these studies basically look at cisatracurium. And then there's a question. So how does cloning affect this? That's for you, my colleagues, to figure out and to publish too. Okay, from the pharmacist, if you're gonna rock your patient, please roll with sedation. So, you're using a paralytic. I've seen this happen a number of times where we paralyze someone and we forget the sedation. We're like, no. Okay, so I'm always gonna ask you as the pharmacist, when you're gonna start a paralytic, did you optimize your sedation? Make sure they're out. They're out so they don't remember. One of my biggest fears is being awake and I can't move, right? So I'll ask you as your pharmacist, how's your sedation? Also, think about the use of concurrent steroids. If you're using cisatracurium, not too bad, because there's not a huge drug-drug interaction. But if you're using rocuronium, vecuronium, based on your availability, you have an increased risk of that post-paralytic neuropathy or myopathy. Then bowel regimen. Make your patients food people. Paralytics, sedation, the sedation, whether it be propofol, diazepines, fentanyl, it's gonna cause the colon to, back up a little bit. So make sure you have a good bowel regimen. Same thing with your VTE prophylaxis, if possible. Your patients are all at high risk of VTE.
No shit.
Of course, they're not moving. And then eye care, taping the eyes closed, the nurses out there, RTs out there, tape them closed, use artificial tears when not possible. Okay, now let's change it up a little bit. To use or not to use in severe ARDS, okay? Do you concurrently use inhaled vasodilators like nitrous oxide or prostacyclins in your ARDS patients? Let's see if this is gonna work. Might take a little while. I'm not
And
sure.
the answer's on the next slide, is that right?
Yes, actually. No, it's on this slide.
Oh.
It should start loading. You should be able to visualize it, hopefully. You should be able to see it. If not, we can do old school raise of hands. Oh, I see it here. Oh.
Oh.
Maybe refresh. I tried to do a dry run earlier. It just needs to refresh. Maybe you need to log back out and log in. I have no clue. But anyways, we can do a raise of hands. Anybody?
Yes.
Nitrous? Prostaglandins? A few? Okay, a handful. So does it really work? First, let's go over some vasodilators. Inhaled nitrous oxide and your prostaglandins are all vasodilators. That's the mechanism of action you can see here. They vasodilate, they improve ventilation, perfusion, mismatch, and in turn, they improve oxygenation short term. Okay. Based on all the studies, I'm not going to put up all the studies, you can kind of read some of the review stuff I had there. They all say there's no mortality benefit. They make us feel better for a little while, but there's no mortality benefit. Nitrous oxide actually increases, there's no benefit to length of mechanical ventilation. You can't get off of the vent. It can also cause a risk of increased kidney injury and issues with like methemoglobinemia. Prostacyclins, again, no mortality benefit either. Again, epoprostenol is your prostacyclin. It'll improve your PA pressures, make you feel better, but clinically, is it going to make a difference for your patient getting out of the hospital? That's the part that is yet to be seen. All right, to use or not to use in severe ARDS, do you currently use inhaled beta agonists in your patients? Hopefully this goes through. I think the responses are open. I might have had a little
was that it's like beside the no yes, because I just do it again and it's like you can only submit once.
Is still having issues?
I tried. I push it. That's it.
Your other right.
It might be because we're logged in on two different computers, I'm not sure.
Yeah, and it looks like I'm logged out now.
Okay, it might be because there's two different computers looking at it, but anyway, raise a hand, inhaled beta agonist, albuterol, and ARDS. I see a couple. Okay, so what is
everybody?
all right, so what is it, what's going on with inhaled beta agonists? Basically, they stimulate the alveolar fluid clearance and may decrease lung vascular permeability and make it less leaky. They do this through the sodium, potassium, ATPase channels and the flow of sodium back and forth through the cells. Albuterol is the go-to nebulized. It has a very rapid onset, less than 5 minutes. It's very short acting, anywhere from 3 to 6 hours. That's why it's dosed like Q4, Q6 hours sometimes. Basically, the data says it doesn't show a benefit. It increases ICU days. There's no benefit in the mechanical ventilation. But there is some data looking at the potential for prevention of ARDS. So this first trial up here, done by Festive and colleagues, this is a phase 2 study looking at formoterol and budesonide for the prevention of ARDS. So and these are nebulized forms, not your Symbicort inhaler. It's like your nebulized forms of formoterol and budesonide, used in combination to decrease occurrence or prevent ARDS. So the phase 2 trial showed progress, and based on that, this ARREST trial came out. This is a phase 3 trial. It's still undergoing study. It's showing potential for the use, so just putting it out there, you may see it if these studies come out to be beneficial in mortality and decreasing the risk or progression to full ARDS. That being said, that's all I have for you. My leaving point is pharmacological treatment of ARDS is not really all about the ventilator. It could be about steroids as well too. Thank you for your time.
We lost it.
I guess I'll entertain questions. Yes.
It just died.
We don't really know. Maybe it's because the studies out there are very not supportive of use of albuterol. So the question, sorry, out there is that albuterol increasing ICU length of stay, like what is the effect beyond that? It's probably the study that you looked at a patient that, maybe didn't have, maybe had some comorbidities going on where they didn't benefit from the use